Okay, so approximately 1/3 of cancer deaths are related to nutrition, physical activity, and obesity. So today I'm going to focus on physical activity and cancer prevention and prognosis. And Dr. Susan Main, who will talk after me, will focus on nutrition, the role of nutrition in cancer prevention and prognosis. And obviously these two behaviors are linked to obesity. And so she and I will also present a little bit of research showing the association with weight loss or obesity and cancer risk and prognosis. So currently, the recommendation is to accumulate at least 30 minutes of moderate intensity physical activity on most, if not all, days of the week. This is a recommendation that came out in the mid-90s, really for cardiovascular disease. There currently isn't really a recommendation for cancer prevention or prognosis, but most of the studies that have been done, observational studies and some of the trials, have looked at this amount of physical activity in relation to cancer risk and prognosis. And getting this amount of physical activity, it's the 30 minutes, say 5 days per week, but some research has shown that whether you do that in 3 days per week or 4 days per week rather than 5 may be associated with the same benefits. Or even some research has shown that accumulating bouts of physical activity, say 10-minute bouts 3 times a day, is also associated with improvements. Once again, most of that research is focused on cardiovascular disease, and the research with cancer, it's really in its infancy. We really have just begun looking at the role of these behaviors with cancer risk and prognosis. Okay, so currently about 60% of US adults are not meeting this recommendation. And this recommendation, you have to realize too, it's also more of a moderate intensity physical activity, a brisk walking perhaps. So it doesn't necessarily mean running or getting involved in marathons or something that's vigorous intensity for longer durations, but just something like brisk walking. But unfortunately, only about 40% are actually meeting it. And a lot of that is access, issues to, it's expensive to join health clubs, or maybe there aren't sidewalks or lighting on streets to perform this physical activity. And then unfortunately, greater than 50% of US adults are overweight or obese. Okay, many observational studies have explored the association between activity and cancer risk, and there are several plausible mechanisms that have been postulated. Most of the studies have been in colon and breast cancer, where there's convincing evidence that there's association between activity and preventing breast or colon cancer. About 84% and 73% of these studies have shown a favorable association with about a 40% reduced risk. So the way these studies were conducted is women or men were asked in their 20s or 30s or 40s what physical activity they perform or participate in, and then they were followed for say 10 or 20 or 30 years until some unfortunately developed colon cancer or breast cancer. And they looked at the activity levels reported years prior, and those who were more physically active had about a 40% reduced risk of developing colon or breast cancer, and that's adjusted for many other risk factors, smoking, age, in some studies even adjusting for BMI. There's also been observed a dose-response relationship with implying that more activity is better than less activity. For the other cancers, prostate, endometrial, lung, and ovarian, there could be a probable or a possible association, but there either haven't been enough studies done yet or they're equivocal. Some show an effect, an association, and some do not. So more research has to be done involving those cancer sites. Okay, so for breast cancer, which I'm going to focus my talk on now since most of the research has been done in breast cancer, there are 2 main mechanisms. One is through these hormones decreasing estrogens. So physical activity may decrease estrogens by either delaying or onset of our menses. So for young girls, maybe the mean age of menarche is around age 11 or 12 years old. But those who are physically active may not go through menarche till age 13 or 14 or 16 years of age. And each year of a delayed menses is associated with about a 10% reduced risk of breast cancer. And then in premenopausal years, in our 20s, 30s, 40s, it may be that the more physically active you are, you have a decrease in the number of ovulatory cycles. So rather than a 28-day cycle, you may have a 35-day cycle. So over a given calendar year, you may only have 10 periods rather than 12 periods, so less exposure to estrogen. And then lastly, in our postmenopausal years, decreasing body fat would decrease the amount of estrogen. So women actually stop producing estrogen via their ovaries, but they continue to produce estrogen in their fat tissue. So physical activity, if it's associated with decreasing body weight or preventing weight gain, that may also be associated with decreasing estrogen levels. So those are three mechanisms by where physical activity may decrease estrogens, and we know from a lot of studies that estrogen is a strong risk factor for breast cancer. So it's hypothesized that if activity can decrease estrogens, it may also decrease breast cancer. Another hormone is insulin and insulin-like growth factors, or IGFs. These are growth factors that increase breast cell proliferation. So if physical activity, once again, could decrease insulin and IGF levels, it may be associated with decreasing breast cancer risk. Okay, so in the Women's Health Initiative, this was a sub-study looked at among, this is women who were healthy, but we looked at the relationship between BMI, physical activity, and two estrogen hormones, estrone and estradiol. And as you'd hypothesize, those who weighed the most and were the least active had the highest estrone or estradiol levels, the black bar. And that those who had the lowest BMI and the most physical activity had the lowest estrogen concentrations. And that's the bar all the way to the left, the light gray. I guess I could use this, right, that bar. But that study, the Women's Health Initiative, is observational. It's not an exercise trial looking at if exercise can actually decrease estrogen concentrations. There's only been one study that's actually done that, looking at whether you randomize women to exercise or not and the effect that that has on hormone concentrations. I was involved in the Physical Activity for Total Health study, which was a randomized exercise trial in about 173 overweight postmenopausal women. And what we showed is that among women randomized to exercise, and it was about that 30 minutes, 5 days per week of moderate intensity activity, most of the women did walking on a treadmill or stationary bicycling or walking in their neighborhood. But those women who did that amount of exercise, there was close to a 13% decrease in estrogen concentrations compared to the control group, which basically they were physically inactive when recruited into the study, and they just sort of maintained that lifestyle. This was over 12 months. And they actually had an increase in estrogen concentrations. What's most important is that this effect was only observed in those who lost body fat, measured objectively with a DEXA scan. So it could be very minimal losses of body fat or up to a greater than 2% loss of body fat. But those who had no change in body fat or actually gained body fat, this association or this effect was not observed. So exercise, perhaps with weight maintenance or even weight loss, favorably changes these estrogen concentrations. But even among controls who lost weight, maybe because of dieting or some other way, but weren't physically active, they actually had an increase. So it's really showing the importance of exercise in decreasing these hormones. Okay, so what really needs to be done in the primary prevention arena is that we need more randomized controlled trials where we look at either surrogate markers of breast cancer risk, so some of these hormones, as well as maybe looking at breast cancer risk as an outcome. That would be tough to do. It would require a lot of participants, 10 to 20,000 women across the country for 5 to 10 years long of a trial to see if exercise could decrease risk. It's been done with the Women's Health Initiative trial, which was a diet trial, but they are expensive, and so maybe perhaps we need more trials looking at these surrogate markers. We could also focus on looking at healthy women or women who are at high risk. Okay, so now I'm going to switch to physical activity and cancer prognosis and what's been done in that area. So the rationale for studying physical activity and cancer prognosis, we know that the survival rate is about 62% overall for all adult cancers, and that 10 million U.S. cancer survivors are living today, and that roughly 22% are breast cancer, followed by prostate and colorectal cancer. Furthermore, women who are overweight at breast cancer diagnosis are at a twofold greater risk for recurrence and death compared with lighter women. Furthermore, women who gain weight, who may be lean but then gain weight, are at a 60% increased risk of death compared to women who do not gain weight. It's thought that obesity and weight gain is what leads to these increased production of these sex hormones, these estrogens and insulin, which in turn increase cell proliferation and then are associated with recurrence. In the HEAL study, the Health, Eating, Activity, and Lifestyle study, we showed that we recruited women at roughly about 6 months after a diagnosis, and we're following them till about 10 years after their diagnosis, collecting information from them, questionnaires, and other information about every 2 years. We showed that in the first 2 years after diagnosis, and this is among 544 women, about 67% of the sample gained weight, and roughly about 4 kilograms, or close to about 8 pounds of body weight, and about 33% lost weight, about 2.8 kilograms. So weight gain is a common problem after a diagnosis of breast cancer. Those who were physically active, or had, I should say, a change in their activity from baseline to 2 years, so the highest level of physical activity, the highest quartile compared to the bottom quartile, had less of a weight gain than those who were least physically active over the 2-year time period. And this is adjusted for some other covariates, some risk factors. Furthermore, high concentrations of estrogen, as mentioned with a primary prevention, are also associated with a 2.5-fold increased incidence of postmenopausal breast cancer. But also, serum levels of estrogen were 2 times higher in patients who had a recurrence than those who did not have a recurrence. And that is why a lot of women who are hormone responsive, who are postmenopausal and have estrogen receptor positive tumors are put on, say, aromatase inhibitors, or if they're premenopausal, they'll put on tamoxifen. These hormonal therapies are basically anti-estrogens. The aromatase inhibitors decrease estrogen levels to basically 0 throughout the body, where the tamoxifen decreases estrogen in the breast tissue, but it may increase it at other tissues in the body. Other sites in the body. So these anti-estrogens have been shown to be strong, it's been associated with decreasing recurrence and decreasing death in breast cancer survivors. So the aromatase inhibitors are now standard of care for postmenopausal breast cancer survivors who are hormone responsive, positive, ER positive. Okay, women with insulin levels in the uppermost quartile compared to women in the lowermost quartile have about a 2-fold increased risk of recurrence and a 3-fold increased risk of death. And observational and exercise trials have shown that physical activity has acute and chronic effects on insulin levels in healthy women. Acute meaning that immediately after exercising, your insulin levels will decrease, and chronic meaning that if you exercise regularly, then from 1 month to the next, they'll continue to decrease over time. Also, cancer and its treatments often produce significant morbidities that undermine quality of life, and exercise has been shown to enhance quality of life both during and after cancer treatments. In this study, we were interested in looking at women who may be physically active before their diagnosis, but because of the treatments and other issues that come about after diagnosis, they may decrease their activity level versus those who maintain them, which could be those who were active and maintain it or never active and they just didn't increase, versus those who were inactive and added exercise into their lifestyle. And we showed that this group, as you would expect, had a lowest risk, it's a hazard ratio, so the lowest risk of breast cancer death, about a 50% reduced risk of breast cancer death compared to those who decreased their activity after diagnosis or maintained those. And this group was not physically active before diagnosis. So this is kind of showing it's never too late to start an exercise program. If you were inactive before diagnosis, it's not too late to start something after you're diagnosed. Okay, so what about exercise interventions in cancer survivors? Most of the studies have been done in breast cancer with a few other studies done in some other sites. However, most of the sample sizes are small, only about 8 to 123 women in the studies. And for short study durations, 2 weeks to say 6 months, only one study was 6 months and the other were all under 12 weeks. So the data, the methodology involved in these studies has not been very strong, and most of the outcomes looked at were improving fitness levels or quality of life, with few studies looking at outcomes such as the surrogate markers of prognosis, some of these hormonal changes. However, even though these studies are short duration or small sample sizes, they have shown that physical activity is safe, it's feasible, it's associated with improvements in fitness and quality of life, decreasing nausea, fatigue, pain, and improving body composition. However, few studies, as I mentioned, looking at these biological markers are actually looking at recurrence and survival as the outcome. So what's really neat after a cancer diagnosis is more exercise trials looking at the actual effect of exercise on changing some of these surrogate markers, and then once again possibly a trial where we look at recurrence or death as the outcome. So we can definitively say that increasing your activity levels after diagnosis has a strong effect on your recurrence. Okay, so because of the gaps in the literature, a couple years ago, I proposed to do an exercise trial looking at these surrogate markers of prognosis to see if exercise is associated with decreasing them. So I initiated the Yale Exercise and Survivorship Study, which was funded by the American Cancer Society. And our goal was to examine the effects of a year-long exercise program on biological mechanisms associated with recurrence and survival. We were interested in looking at mammographic breast density, insulin, some of these hormone levels, body fat, and quality of life. Mammographic density basically is what we can do is we can retrieve your mammogram, and there's you can digitize it or scan it through what looks like a kind of a copier machine, and then there's software to look at that digitized mammogram. So you can look at the different tissues in the breast. There's fat tissue or there's stromal or epithelial tissue. And we can look at whether exercise changes the tissue composition in the breast. Other studies have shown that the dense tissue, which is the stromal or the epithelial tissue, is associated with a 4 to 6-fold increased risk of breast cancer. And studies have shown that women who take hormone replacement therapy have an increase in their dense tissue. Women who take anti-estrogens, such as tamoxifen, have a decrease in breast density tissue. So this is a modifiable factor, this breast density. So if we can show that exercise decreases dense tissue, that's another potential mechanism. So what we did, this study was initiated a couple years ago, and we actually just finished all the data collection, and we're analyzing data and submitting it for publication. But what we did is we recruited about 75 women who were postmenopausal, who were diagnosed with breast cancer about 1 to 5 years ago, and we checked their eligibility via a telephone call, and then they came to Yale for a baseline visit where they signed informed consent forms, and they completed a lot of questionnaires on physical activity, quality of life. We measured their body fat and bone density at the Yale GCRC, and then we randomized them to either an exercise program or a usual care group. The exercise, once again, it was that 30 minutes, 5 days per week. In the usual care, we told them they could exercise if they chose to, but we couldn't offer them our program until they were done with the trial. Unfortunately, even though they were told they could exercise or start a program, very few actually did. We then did some follow-up assessments at 6 and 12 months. The average age was about 55 years old, highly educated, about 54% with a college degree, mostly non-Hispanic white, and about 63% were stage 1. And on average, about 3 years since their diagnosis. And women exercised on average about 123 minutes per week, which we were really excited to find this because these women were physically inactive before the trial. They had historically never really participated in exercise, but always had wanted to, but there were certain barriers making it difficult for them to exercise. So we were able to get them up to about 123 minutes per week. This was a combination of a supervised 3 days per week at a local health club and then 2 days per week on their own. So there was a lot of, they had like a personal trainer which really encouraged them and helped to increase their activity levels. So what did this translate into? If we look at body fat, which is a strong surrogate marker of prognosis, we showed among the exercisers, they had almost a 1% decrease in body fat, but the controls had about a half a percentage increase in body fat. So that the net difference between the two groups was about a 3% difference between the two groups. That may seem small, but it's actually clinically significant difference between the two groups. And this is actually just the 6-month results. So if you assume if you continue to participate in physical activity, if it's not necessarily associated with continued weight loss, it is associated with weight maintenance, where if you don't participate in exercise, that could lead to some increases in weight and body fat over time. And then for looking at insulin, a strong growth factor for breast cancer, we showed decreases among the exercisers and increases among the control group for about a 17% difference between the two groups. Also, among the exercisers for both these surrogate markers, there's a dose-response effect. Those who did more exercise had greater losses in body fat and greater decreases in insulin levels. So this is encouraging results that exercise, a randomized exercise trial can favorably change these surrogate markers for breast cancer prognosis. So we finished the data collection, but what we're continuing to do now is to invite the women back for a clinic visit 1 year after they finish the study to see if they've maintained their physical activity levels, if they've continued to lose body fat, or if they've maintained any weight loss, their body weight, and to also ask them more questions related to psychosocial, their quality of life. So we're currently doing that right now. We also have a large-scale multi-site trial under review that would actually be a 5-year-long intervention, randomizing women to exercise or control group and following them until either recurrence or a death occurs. So that will really be the definitive study showing whether exercise improves prognosis. Lastly, a recent study showed that about 84% of cancer survivors preferred to receive exercise counseling at some point during their cancer experience, and 77% preferred to receive this counseling from an exercise specialist affiliated with a cancer center. So, fortunately, just last fall, we opened the Connecticut Challenge Survivorship Clinic here at Yale Cancer Center, which was, you heard a talk yesterday and last evening about. And this clinic, which there's very few across the country, but this clinic sees about 16 to 20 patients who have completed their adjuvant therapy for any cancer. And they see a nutritionist, a physical therapist, a social worker, an APRN who focuses on these symptom assessment and management. And so one-time visit that they come and they can kind of get information on all these health behaviors that are associated with their prognosis. So we will look at whether this clinic visit is also associated with improvements in these behaviors, and if so, these hopefully it will provide evidence that these clinics are worthwhile and should be opened up in other hospitals and cancer centers around the country. Okay, lastly, the American Cancer Society and the American College of Sports Medicine have recently decided to develop a certification program on physical activity and cancer for personal trainers, physical therapists, nurse practitioners, and other health professionals to be certified in how to exercise train those who are either receiving cancer therapy or have finished their therapy and want to improve their physical activity levels. So this will be rolling out in the fall, and if you're interested in getting certified, we're going to be doing some beta testing where it'll be free of charge, where you're actually helping us to refine the exam, and so you could be a part of that. Or you could actually take the exam when it's online starting next January and get certified. What this will also be is linked to oncologists and health insurance companies so that if you're certified, the patients that you exercise train can get reimbursed through their insurance company. So in conclusion, adjuvant treatments for breast cancer lower disease mortality about 25 to 40%. Physical activity after diagnosis may lower disease mortality about 40 to 55%. So therefore, advising activity after cancer diagnosis may help patients as much as standard treatments. Thank you.